Welcome to All in All.
Great to be diving into this.
So, if you're listening, chances are you're a dialysis RN or a tech. Or maybe you're gearing up for a new role in a clinic.
Right. And you know that really understanding the clinical side of things, especially safety, is just, well, non-negotiable.
Absolutely. So today, we're tackling a really critical area. Safety and complications in hemodialysis.
We're planning to kind of drill down into it, start broad, then get into the nitty-gritty clinical details you really need.
Think of it as a deep dive, pulling together insights from studies, guidelines, the key resources.
Exactly. We've gathered the info, and our mission today is to unpack it together.
Highlight the key takeaways and hopefully give you some practical knowledge you can use right away in your practice.
Okay, so where do we start? Maybe with just how common complications actually are.
Good idea. Because it might be more frequent than some people realize.
It really might.
Yeah.
There was one pretty significant study looked at over 900 sessions.
Right.
And it found complications were reported in, well, a lot of them. It's not some rare thing.
So not an outlier event,
Right.
Something you might see often.
Pretty often, yeah. And the number one complication they found, arterial hypotension. Low blood pressure during treatment.
And how often did that pop up?
Get this, 30.5% of sessions. Almost a third.
Wow. Okay, that's a really high number. And I assume it's not just a quick fix. It impacts the treatment.
Oh, absolutely. It can really derail things. That same study found hypotension was the most common reason they had to actually stop a dialysis session early.
The most common reason.
Yep. Accounted for 37.2% of all the times they had to suspend a session.
So incredibly common. And the top reason treatments get cut short. That really tells you how vital it is to manage.
It really does. And besides hypotension, the sources also list other things you'll definitely run into.
Like what?
Things like hypoglycemia, muscle cramps, nausea, vomiting. Headaches are pretty common too. Chest pain, back pain, sometimes even fever and chills.
So the big picture here, for anyone working hands-on with patients, is that you just have to be ready, right? Skilled monitoring, having intervention plans, it's critical for every single session.
Exactly. Patient safety isn't just about reacting, it's about anticipating how often things can happen and being prepared.
And given that hypotension, or IDH, intradialytic hypotension, is number one,
Right.
we should probably dig into that a bit more.
Definitely warrants a closer look, because it's not just common like 10-12% in outpatient setting.
Which is still pretty common.
Right. But it's also linked to some serious stuff long-term. We're talking potential damage, like ischemic stress to the heart and brain.
Temporary lack of blood flow.
Yeah. And even disturbingly linked to increased patient mortality over time.
Okay, that's serious. So how do we actually define IDH? Does it matter exactly how low the pressure goes?
That's a great point. Definitions do vary a bit, but the sources suggest that the absolute lowest systolic pressure reached during the session, the nadir seems to have the strongest link to those bad outcomes.
So it's not just any drop, but hitting that absolute low point.
Precisely.
What's going on physiologically? What's the root cause?
Well, at its core, it's about reduced effective blood volume. You're pulling fluid out during dialysis.
The ultrafiltration.
Right, the
Yeah.
UF rate. And sometimes that rate is faster than the body can pull fluid back into the blood vessels from the surrounding tissues.
So the tank is emptying faster than it can be refilled, essentially.
That's a good way to put it. This mismatch affects plasma tonicity, and the whole system struggles to maintain pressure.
Makes sense. And there are factors that make certain patients more likely to experience this, right? Things you need to look out for.
Oh, definitely. Patient factors are huge. Things like older age, other health issues.
Heart problems.
Yeah, reduced cardiac reserve is a big one. Diabetes, autonomic dysfunction, problems with the body's own blood pressure regulation system.
And even things like how well they stick to their fluid limits between treatments.
Absolutely. Patient compliance plays a role. Then you've got the treatment factors themselves.
Like how fast you pull the fluid off.
Exactly. The ultrafiltration rate is critical. Also, how you set that post-dialysis target weight, because that determines the total volume you're removing.
And the dialysate itself, the fluid we use.
Yes, its composition matters. Sodium levels, calcium levels, even the temperature of the dialysate can influence stability. Lower dialysate calcium, for example, has been linked to more IDH in some research.
Any other, maybe less obvious things?
Sometimes reactions to the circuit, the tubing and dialyzer, certain medications the patient takes. Anemia and low albumin levels are also mentioned as risk factors.
Is there technology that can help predict this? Like monitoring tools?
There are tools, yeah. Things like relative blood volume monitoring, or RBV, and central venous oxygen saturation monitoring can provide clues.
But they're not foolproof.
No, definitely not perfect predictors. Patient responses can be really variable, you know? Even the same patient might react differently session to session.
So for the nurse or tech at the chair side, it really comes down to understanding all these potential causes and risk factors.
It absolutely does. Careful pre-assessment is key, checking weight gain, symptoms, knowing their history before they even get hooked up.
And then just being really watchful during the treatment.
Vigilant monitoring throughout, especially for newer patients or those with significant uremia. And paying attention to those dialysate settings like we mentioned.
You mentioned the ultrafiltration rate. Are there different ways to approach the fluid removal to maybe reduce the risk?
Yes, there are strategies. Instead of pulling fluid off really fast at the beginning, sometimes using a constant rate or even a slowly decreasing rate throughout the treatment might be less stressful on the system compared to, say, intermittent or very high initial rates.
Okay, that makes sense.
Yeah.
So IDH is clearly a major focus. But what about other complications? Headaches come up a lot.
They do. And headaches can be tricky because the cause isn't always obvious. It could be physiological, right? Maybe blood pressure shifts, hypertension even.
Or pulling too much fluid off.
Exactly. Related to an inaccurate dry weight assessment, or sometimes rapid electrolyte shifts, like in disequilibrium syndrome that's thought to be related to urea being removed faster from blood than the brain.
But it's not always the dialysis process itself causing it.
No, patient factors play a big role too. Anxiety, stress, even caffeine withdrawal can trigger a headache during treatment.
So what's a key preventative measure the sources mentioned for headaches?
Getting that target dry weight assessment as accurate as possible seems fundamental. Removing the right amount of fluid is key.
Makes sense. How about itching? Pruritus. That's another common complaint.
Very common. And again, multiple potential causes. It could be something simple like dry skin, which many dialysis patients have, or maybe an allergy.
Or something more systemic.
Right. It can be a sign of deeper issues like secondary hyperparathyroidism or inadequate dialysis leading to uremia, especially with high BUN levels.
So the itching could actually be a clue that the dialysis prescription needs adjusting.
Potentially, yes. Treatment often involves making sure the dialysis is adequate, clearing enough waste, balancing electrolytes, and of course, managing the skin itself with lotions or meds if it's dryness or allergies.
Okay, let's shift to something that sounds more immediately serious.
Yeah.
Chills and fever during a treatment.
Yeah, this is a red flag. It requires prompt action. Symptomatic treatment might involve giving normal saline if their pressure drops, maybe oxygen if they're short of breath.
But the main action for the nurse or tech.
Call 911 immediately. This is considered an emergency situation that needs evaluation beyond the clinic.
Got it. What about dialyzer reactions? You mentioned reactions to the circuit earlier.
Right. These can happen. Sometimes it's called first-use syndrome, like a reaction the very first time a patient uses a particular type of new dialyzer.
Or it could be an actual allergy.
Or a true hypersensitivity to the membrane material itself. Or maybe residual sterilant left in the dialyzer.
What kind of symptoms should you be looking for?
It's a really wide range, which can make it tricky. Could be milder things like back or chest pain, anxiety, maybe hives or just general itching.
But it can get worse.
Oh, yes. It can escalate rapidly to severe symptoms, sudden hypotension, difficulty breathing, wheezing, chest tightness, nausea, just a vague feeling of discomfort, and in the absolute worst case, even cardiac arrest.
That sounds incredibly serious. So if you suspect a major reaction is happening.
The absolute critical first step is stop the treatment immediately. Disconnect the patient from the circuit if you suspect an anaphylactic type response.
Okay. Stop treatment. Got it.
Yeah.
Now, so much of dialysis safety revolves around the vascular access. Let's talk types.
Sure. You've basically got three main categories, arteriovenous fistulas, or AVFs.
Where you connect an artery and vein directly.
Exactly. Then arteriovenous grafts, AVGs, using a synthetic tube, and then central venous catheters. Those can be temporary, non-tunneled ones, often called CDLs, or the more permanent types like perm caths.
And here's something that really jumped out from the sources, the mismatch between what's recommended and what's sometimes seen in practice. AVFs are preferred, right? Lowest infection risk.
Absolutely. Lowest infection and clotting rates. They're considered the gold standard.
But one study found they weren't the most common type used.
Yeah, it was quite striking. In that particular study population, a huge majority, 92%, were using those dual lumen central catheters, the CDLs.
92%.
While perm caths were only 4% and AVFs just 3%, it's often related to patients needing dialysis urgently before a fistula can mature, but it highlights a challenge.
And that difference is massive from a safety perspective because of infection risk, isn't it?
Huge difference. Catheters just have a much, much higher risk of infection compared to fistulas or grafts. One source quantified it. Uncuffed catheters were something like 22.5 times more likely to get infected than an AVF.
Wow, 22 and a half times.
Yeah.
That really hammers home why infection prevention is just absolutely paramount, especially if many patients are using catheters. Where does that prevention start?
It starts with you, the caregiver. Hand hygiene. It sounds basic, but it's number one. Proper use of PPE gloves, masks, gowns when needed, and strict aseptic technique.
What does aseptic technique really mean in this context?
It means doing everything possible to prevent contamination during procedures, especially when you're connecting or disconnecting the lines or accessing any part of the system, using sterile supplies correctly, not touching things you shouldn't.
And that phrase, scrub the hub, what's that about?
That's critical for catheter care. Every time you access the catheter hub for connecting lines, flushing, drawing blood, you have to vigorously scrub it with an appropriate antiseptic like chlorhexidine or alcohol for the recommended time. Same goes for any needleless connectors or injection ports on the lines. They are direct entry points for bacteria.
So scrub every access point every time.
Every single time. The sources also mention preferring closed catheter access systems where possible, as they seem to be linked with fewer infections.
What about the environment, the dialysis station itself?
Super important. Every surface is considered contaminated after a patient uses it. So thorough cleaning and disinfection of the machine, the chair, the tray, everything between each patient is essential.
Is there a specific way to do it?
Yeah, you work from cleaner areas to dirtier ones. You need to make sure the surfaces stay wet with the disinfectant for the required contact time. You can't just wipe and dry immediately, let it air dry. And any reusable items like blood pressure cuffs need proper cleaning too.
What about preparing medications like saline flushes?
That needs to be done in a designated clean area, away from potential contamination. Using pre-filled saline syringes from the manufacturer or single-use vials is preferred over multi-dose vials to reduce infection risk.
Your role extends to teaching the patient too, right?
Absolutely. Patient education is key, teaching them about hand washing, how to care for their access site at home, like not scratching or picking at it.
Recognizing problems.
Yes, teaching them the signs of infection, redness, swelling, pain, drainage, and making sure they know exactly who to call if they notice anything concerning when they're not in the clinic. Empowering them is part of the safety net.
So what specific signs should you be looking for that might indicate an access infection?
At the site itself, you're looking for tenderness, redness, erythema, warmth, swelling, or edema. Maybe the area feels hard, that's induration. Any discharge, clear or pus-like, or bleeding that doesn't start easily.
And for fistulas and grafts, it can involve the vessel itself.
Right, you could have an abscess forming or an infected clot inside, or even an infected aneurysm, which is a weakened, bulging area. Also, something noted is that old, clotted-off grafts, even if they aren't being used anymore, can sometimes harbor a hidden infection.
Okay, and if you do suspect an infection?
Management usually involves antibiotics. Could be topical or oral for milder local things, 4V antibiotics for more serious infections. Sometimes surgery might be needed. For catheter infections, they might use antibiotic lock solutions, filling the catheter with concentrated antibiotics between treatments.
All right, so that's infection. Another aspect of access safety is making sure it's actually working well enough, right? Getting enough blood flow.
Exactly. If the machine keeps alarming for low blood flow, or you just can't achieve the prescribed rate, that's a concern.
Could it be something other than the access itself?
It could be. You always troubleshoot first. Is the needle placement optimal? Is the patient's blood pressure maybe a bit low, affecting flow? But yes, it could definitely indicate a true problem with the access, like a narrowing or stenosis developing.
How do you monitor that objectively, beyond just the machine readings?
There are technologies for measuring the actual access flow, like transonic or BTM modules. Guidelines recommend using these for regular surveillance.
How regular?
Generally, about every 3 months for fistulas and grafts, but more often, like monthly for patients who have grafts or anyone who's had previous access procedures like angioplasty, or if you just clinically suspect something's wrong.
What kind of clinical signs would make you suspect a problem?
Things like consistently rising venous pressures during treatment. If it becomes noticeably harder to needle the access over time, obviously the poor blood flow on the machine, or if you see a drop in how well the dialysis is cleaning the blood, measured by things like the URR, the urea reduction ratio.
And if those signs are present, or the flow measurement is abnormal.
Then you need further investigation. Usually that means sending the patient for imaging, like a fistulogram or venogram, to actually see inside the vessel and find out what's going on.
Okay, one last quick but important point.
Yeah.
Dialysate parameters, specifically sodium, seem simple, but the source is stress getting it right.
It's crucial, yeah. Because the sodium level in the dialysate directly impacts fluid shifts and blood pressure. You need to make sure the machine is actually delivering what you've prescribed.
And the way to check that is the conductivity reading.
Exactly. The machine gives you a conductivity reading. There's a handy rule of thumb. The conductivity should be pretty close to 1/10 of the prescribed sodium value.
Can you give an example?
Sure. If you prescribe a sodium of, say, 138 ml EQL, the conductivity should read around 13.8 millisimeter. There's usually a small allowable range, but it should be close.
So conductivity is your verification tool.
Right. And sometimes you might actually need to tweak the prescribed sodium setting slightly up or down on the machine to get the conductivity reading exactly where you want it, ensuring the delivered sodium concentration is correct. It's a practical tip to make sure intention matches reality.
This has been incredibly thorough. We've really covered a lot of ground, from how common complications are, especially IDH, to other issues like headaches and itching, managing emergencies like chills or reactions.
And spending significant time on vascular access, the different types, the absolute criticality of infection prevention, monitoring function, it's also interconnected.
It really highlights how your knowledge, your assessment skills, your vigilance as a dialysis RN or tech are just fundamental to keeping patients safe during every single treatment.
Absolutely. Your ability to spot subtle changes, to understand the risks, and to act quickly makes all the difference.
It really does. Thinking about how frequent something like hypotension is and the monitoring tech like RBV that exists, it raises an interesting question for the future, doesn't it?
How so?
Well, how do we best leverage technology, maybe even more advanced predictive monitoring or biofeedback systems that are mentioned sometimes, while still keeping that essential human element? That skilled nursing judgment and intervention has to remain central, right? Finding that perfect balance seems like an ongoing challenge for the field.
A really important balance to strike, for sure.
Thanks for listening to All in All.